Welcome everyone to our third event in our Global Mental Health Speaker Series this academic year. I'm really happy to see you all and hope lunch is delicious. I'm gonna have some later. I'm really delighted to have Shannon Dorsey and Larry Wissow here with us today. They are faculty in our the UW Consortium for Global Mental Health. I'm the program manager. My name is Leah Wen. I'm the program manager for the UW Consortium for Global Mental Health. And Larry and Shannon are two of our most active faculty in the consortium, and they both work within the child trauma realm. Larry was the until just very recently stepped down as the chair, division chief, yeah, there we go, for child psychiatry at Seattle Children's. And Shannon has worked for many years scaling up, she's a professor in psychology and has worked for many years scaling up child trauma and trauma-focused CBT interventions for children. So I'm really excited to have them here in conversation regarding sort of their respective areas of expertise within this realm. We have these conversations to create like another way of thinking about the expertise that we have here at UW, right? Like we often get single presentations of research, but I think it's really exciting to, for people who are experts within their field, but in slightly different areas, to be able to have a conversation that like grows the shape of the field in our minds. That there's sort of like this potential expanding quality to these conversations. I think is really exciting. So I'm delighted to have them here. We have a little bit more of an informal setup. There won't be a PowerPoint. Yeah, I just really love these conversations. So I'm so happy you're here to participate both in person and the folks joining us online. I also just want to extend my gratitude to the land and to the Indigenous people who have cared for this land from all the way back, right? And that cared for their children on this land, that cared for their children's, anything that happens in our child's life in partnership with this land, and take care of this land in such a way that it still takes care of us today. I feel very tended by this place, and when I have grief and trauma in my life, the land is the first place I go to. And the capacity of the land to do that is very much because of how it's been loved and tended and cared for generations by the people that lived here. Yeah, when land is traumatized, it's not as able to hold our trauma. Anyway. I've been running around. I'm just gonna arrive. It's been a really big week, right? There's a lot happening in the world, and so it feels like a good day to be talking about child trauma and the interventions for that. And let us all sort of call our own child selves into this room and let ourselves be tended to. So thank you. Please come on up, Larry and Shannon.
That was really loud online. I'm really sorry. Really sorry.
Do you want me to give you a time warning?
Oh, yeah, I just brought my phone. Oh, okay. Hi, everybody. Thanks so much for joining. And please get up and grab food. The sandwiches are awesome. It's hard to pass up a Cougar Mountain cookie, so just grab what you need as you go, and it'll be pretty informal, I think. Well, we're super excited to be here, and we thought versus Leah going into a long introduction of each of us, we would introduce ourselves, say a little bit about what we do and why, we hope this conversation is definitely gonna be fun for us. Hopefully it's fun for you. I'm Shannon Dorsey, as Leah mentioned. I'm a full professor, sorry. I'm very confused. I have a sick child at home today and yesterday, so it throws your mind somewhere. But my focus has been on, as Leah said, how we can most effectively treat child trauma when kids have been exposed to trauma. And if you don't know what child trauma is, which I think probably most of you do, but it's any interpersonal violence, community violence, abuse, neglect, different ways that children are harmed and traumatized. And then what we're trying to figure out, and what I think we have some great evidence for, is how do we treat child trauma so that kids aren't seeing everything through a trauma lens. They're able to get back to playing, to being connected to people, to not thinking about safety all the time, thinking about safety when it's appropriate, but not having that be something that drives everything that they do. And I'll talk about this a little more as we go. See, is this one giving feedback? Yeah, I keep trying to move it around slightly. I can't seem to figure out.
Could be me too.
One option could be
To trade that back and forth. Yeah, because I kept trying to move it. Okay.
turn this off. Turn it off while Shannon's on.
Oh,
You
okay.
can
Oh,
turn
that
back
did it.
on.
It's just those two.
Yeah, so maybe, and you can turn that one off.
Yeah,
as
we can
well.
also, okay. The neat thing about child trauma treatments is I think they make a lot of sense. If you think about what someone who's experienced violence or a break of trust, because many children who are harmed in an interpersonal way are harmed by someone they know quite well, not usually a stranger. So there's an interpersonal violation of trust, not just that you were maybe physically abused or sexually abused. A lot of my work is where children have experienced the death of one or both parents as well, which is both traumatic and then changes how your caregiving is approached, because now you don't have one or both of your parents involved in that role. And in low and middle income countries where resources are more stretched, it can also cascade into other challenges for a child. But the treatment, hopefully, as I talk about it, will make sense. And we'll have time for questions at the end if anyone has questions about what the treatment looks like. But the first half is basically teaching kids skills to deal with the emotions and feelings and worries and thoughts that they have so that they can feel more comfortable, they can be less worried, they can get sleep at night, they can focus on their schoolwork, they can interact with their friends. And then it involves talking about what you went through, because if you think of anything that someone avoids or doesn't want to think about, so, if you're scared of shots, you might not want to get the latest vaccines. If you're scared of thinking about your parent who died, you might not want to go by your parent's grave. You might not want to use the plate that they ate off of. But those things distance you from staying connected to someone who died. And in situations of physical abuse or sexual abuse, you might avoid all adults or all men if you were sexually abused by a man. And then you miss out on critical relationships that are important, even though one relationship harmed you. So we have kids talk about what they went through with a trusted counselor. And then they also talk about it with a trusted guardian who's been prepared to help support them, because it's hard to hear kids' stories about what they've been through. We call that exposure. And for anxiety disorders, exposure-based treatments are the most effective treatments. But of course, when you've been traumatized, we're not going to re-expose you to the trauma. We're going to re-expose you to the memory so you can talk about what happened. And it's a little bit like cleaning out the wound. We use this analogy with kids when we're treating them. If you've gotten an injury and you need to clean out the wound, it stings a little to put the medicine on it to make sure if, you fell and scraped your arm and it has some dirt or something, you need to clean that out. It stings a little, but to heal, you have to do that cleaning out process. And so for kids to talk about the experiences they've been through, that is part of cleaning out that process. And as I talk about some of the work we've done in Kenya and Tanzania, part of that process for kids who've lost a parent who died is looking at that parent's picture. It's touching the plate they ate off of. It's walking by the grave and being able to honor and grieve that parent, not just distancing from them and not being able to talk about them. It also involves talking about some of the hard stuff, like if your mom died, what were some of the hard things with your mom, not just the good times, because in every culture in the world, and it's stronger in some cultural groups than others, but we don't talk badly or say anything bad about someone who died. But when you had a fight with someone or a difficult time, you also need to be able to talk about that so that you're fully connected and open to the relationship you had with that person. So skills at the beginning, and then exposure to the memories of what happened to you, and things that remind you of the person. So one other example when it's not death, and then I'll pass it to Larry, is, for example, I had treated a child who had been given a peanut butter and jelly sandwich as a reward for abuse and not telling. And you can imagine for a kid, at least in the US, if you can't have a peanut butter and jelly sandwich or smell a peanut butter and jelly sandwich because it reminds you of a violent relationship, you're going to be triggered all the time about what happened to you. So part of the exposure for that kid was smelling and seeing peanut butter and jelly sandwiches till we could disconnect the abuse from the trigger. Does that make sense? So a lot of trauma treatment is that, and we have a lot of great evidence in the US, and we have a lot of very strong growing evidence in other countries, cultures, and contexts for these types of treatments. And I will really look forward to talking about them more. Does that give you a sense, though, of what the treatment is like if you're not a mental health person? How many people in here are mental health focused? Because then I'll. Okay, so a few, but not all. Okay, then I'm glad that I did that. I feel like sometimes in mental health, you live and breathe it, so you forget the stuff you didn't know before you were mental health. So I'm gonna pass it to Larry for his introduction. Oh, sorry.
Is this the right thing?
Yeah, go with
It
that.
works. Okay, great. Well, thank you, Leah, for the introduction and also for the soothing music as we walked in. It's definitely a high arousal time, and so it's great to be in a quieter space for sure. So I'm gonna tell you a little bit of story about me that sets up, I think, the contrast between the two of us, despite the fact that we've been friends for a very long time, is that on this side of the flowers is kind of the idea of specific and episodic treatment, and to some extent on this side of the flowers is the idea that every interaction with the healthcare system should be both a potential entry point for getting that kind of treatment, but also should be healing in and of itself. And so my story is that I started out my professional life as a pediatrician, and as a pediatrician who was focusing on child abuse. And at least back in that day, and the kids now like to say, gee, you're so old, you're older than my grandmother. I say that, yes, that's true. You know, my first pet, was T-Rex. And they say, no, it's not true. So anyway, back in that day, a lot of being a child abuse or child advocacy pediatrician involves basically doing forensic science. I mean, you looked at x-rays and you looked at pictures of people's burns and you said, how could this have happened? And is the story plausible? And obviously that's like way too late in the game. So we had this idea that, well, would it be possible to have interactions with people in the course of their medical care, whether that's the parents or whether that's the kids, where they would feel comfortable talking to you about the things that were troubling them, and in particular about their exposure to violence, whether that was domestic violence between the partners in the home or whether that was feeling like my child is so frustrating to me that there are times when I just wish I could strangle them. And that led us down the road to thinking about, well, what is it about things that go on in patient-provider or doctor-patient, interactions that allow people to elicit sensitive sorts of topics. And so we've kind of gone on from there, thinking about, well, what are the parallels between that sort of patient-centeredness, that evocative sort of a relationship building approach and psychotherapy. And in fact, they're really very, very closely related. And so my work has focused mostly on trying to think about how you can move mental health skills into primary care, and in particular, how you can get primary care clinicians to be purposefully therapeutic, just doing the things that they do all the time, and then secondly, can you actually teach them some of the kinds of skills that Shannon, teaches people, and have them be able to use that either on the fly or deliberately in the course of their practice. So, am I supposed to ask you a question now?
Well, I think
You're supposed to ask
started,
me a
yes,
question.
and
Okay.
I'll keep this and then I'll turn it off. So we wanted to situate this conversation also in the context of, there was some Lancet Commission work on youth mental health. Many of you are probably aware of what we've seen the most in the US context, which is that the Surgeon General has said there's a crisis in youth mental health needs, that youth mental health needs are escalating. We saw a lot of impact during COVID, and it was hard to keep a workforce in the US that could serve these youth because people were leaving those positions and not staying in them. Larry was part of a commission on youth mental health for the Lancet, and what'd you say? Okay, he'll talk. And okay, yes, I believe he will say, or maybe he just gave me the paper. But what we wanted to do was situate what we're talking about today in the context of this commission that just recently came out on youth mental health globally, because I think typically some of what we hear is very Western based or very industrialized, high income country based, and we don't get as big of a large picture on where youth mental health is worldwide. And I'll turn this off.
Okay, now it worked great. So I was not a direct part of the Lancet Commission. I am a shameless distributor of the report. And I was involved with some of the WHO work that ultimately went into it. But the Lancet Commission was a group of people who got together and tried to look at the state of youth mental health. And I think you can sum up their findings in a few places. I mean, one is that there is pretty strong evidence that it's not just that demand for services are going up, but the actual prevalence of youth mental health problems seems to be increasing, globally. And they say there really are the explanations for it seem relatively clear. I mean, one is the huge growth in inequality and income disparities that we've seen in so many places and continues. The second is climate change, and it's whether that's the indirect stress of just sort of not knowing what's going on, or it's the actual displacements and changes in lifestyle and things that have already been prompted by climate change. Another is the really unprecedented level, I don't have to be telling you this, the unprecedented level of armed conflict and displacement in the country, in the world. The refugee displaced population, I think, is at its highest ever, and a huge proportion of those individuals are kids, and kids are much more likely to be involuntarily displaced than our adults. You can throw in social media here, depending upon where you land. It clearly amplifies all of these other things. So what the Lancet Commission said was, self-servingly boiling it down to three things. One is that we really have to expand our conception of youth mental health up through age 25, because people have said over and over again that brain development really doesn't reach its sort of adult level until you get to 25. At least, and us guys are laggards when it comes to that. But it also doesn't make sense for us to create child health systems that dump people out at age 18 when we know that the sort of late adolescence, early adulthood is the peak age of onset of serious mental health problems. And so we often diagnose people and get them into treatment and then dump them out at the end of the child conveyor belt there. The second thing they said was that if we want to try to really expand access to mental health care, it's got to be through the primary health care system and through schools and places that kids go, because we will never be able to have enough specialized mental health services. And the last thing they said, which is certainly music to many people's ears, is that we have to take this wonderful book, the Diagnostic and Statistical Manual of the DSM, and gleefully take it over to the latest dumpster or fire and get rid of it. That they put into words what others have said and what clinicians have found for a long time, that the categories that are in the DSM, especially as they relate to children and youth, are not particularly useful because everybody has 6 diagnoses. You can never find someone who's depressed who isn't anxious. It's hard to find anybody who's traumatized who isn't anxious and depressed. People can have a little bit of obsessive compulsiveness. At any rate, we need transdiagnostic or different ways of sort of lumping these things that help us guide treatment, and that's something that you've thought a lot about, so that's something you can talk about. And the other thing that they've said too is that our current ways of screening for these things, which are, of course, have been incredibly useful in the sense of institutionalizing mental health care in places, because the minute someone tells you you have to give out a questionnaire, that means you gotta have a questionnaire and you have to write down the answers, and that's wonderful. That's moved the needle in the primary care world enormously. But the trouble is the kinds of things that are being detected there are too late. You know, by the time you meet criteria, by the time your PHQ score is high enough, we've already missed a huge, opportunity for prevention. And as Tom Insold, one of the past heads of the National Institute of Mental Health here in the U.S., has very accurately but sort of sadly said, is that most of our sort of adult mental health care is palliative care right now. I mean, by the time you get to the point where you have a serious mental illness, even I think some of the kinds of traumas that Shannon's working on, you're helping people deal with something that they're going to live with for a very long time. And we'd love to be able to try to intervene at some point when there's actually a chance that it might just go away. Anyway, so what am I supposed to ask you now? I'm supposed to ask you about how we actually manage to expand this care through people who haven't had to have 65 years of training.
So many of you probably know about task sharing or task shifting. People know that term. If you're not in mental health, you may know that term from other places. But it's basically training paraprofessionals or non-professionals to deliver mental health care. The building right behind you is Kincaid. That's one of the psychology buildings. That's Guthrie. And then I'm in Kincaid, which is just right over there. And in mental health, I think, just like in any other field where there's licensure and a need to protect a quality of care, that there can be some gatekeeping. So, you might assume a PhD delivers the best care, and then a master's person would deliver the next best care, and it's the degrees that matter. And that's actually not true. So we don't have any evidence that licensure ensures that you deliver better care. It is just a way to make sure no one's sued that you've passed some state licensure exam. One of my most favorite things about all the work I've ever done is training community members to deliver treatments in their own communities with folks that they overlap with contextually in terms of neighborhood, city, country, region, home type, and from the same tribe, culture, to be able to deliver care. And we have had exceptional success training lay individuals who just know how to interact with people. Maybe you did recruiting on the street for people to be part of studies or to be part of a sanitation program, but you have really good people skills. And we know how to teach people to do some of these very high quality evidence-based treatments that in the US, and this is also problematic, might only be delivered by people with higher level degrees, and to do it in a way that we have exceptional outcomes. Now, we don't train a community member to deliver a mental health treatment in 2 days. If you are here and if you're in the US and you're a master's level provider, a PhD level provider, you might come to a training that we offer and it's 3 days, and then we give you some follow-up consultation. I don't actually think that's okay for master's or PhD level people either, because these treatments are hard to learn. One of my graduate students, Clara Johnson, is here. Aren't they? They're not that easy to learn, even with advanced mental health training. With community members, here, there's no support to bring someone out of their job and position and client care to do a week-long training. You're just really hurting. And in Washington, I work with community mental health. So I work with organizations that provide their care for Medicaid, Apple Care, underinsured or uninsured kids. So that's the work that I do in Washington State. But it's hard to pull someone out of a setting like that for 5 days to get treatment. Luckily, when we're training lay providers, there's lots of support to do a 2-week training. We spend very little time lecturing. We spend almost all of our time showing someone how to deliver one of the skills. Then they practice it with feedback in small groups. People support each other, the trainer supports them, and it's really a practice space. It'd be like learning to cook or learning to do any sports activity, where most of it is practice with feedback and coaching. And we have really exceptional outcomes. So going back to 2009, one of the projects I've been the most involved in was in Tanzania and also in Kenya, where a colleague of mine that's in public health was studying outcomes for youth who'd lost one or both parents. Because food scarcity becomes an issue, there's less access to schooling because of school fees. If you're a woman and you took on your sister's children, now you have more mouths to feed, and it's a challenge for kids to be cared for well. And so we wanted to understand, or my colleagues wanted to understand, what do children who've been orphaned need, and how do they do compared to children who've not been orphaned? And do children who've been double orphans who've lost both parents, do they do a lot less well than single orphan children or children still living with their parents? They were not planning to focus on mental health, but as they talked to guardians about needs, and they did, cognitive tests, they did growth tests to see if kids were growing, the guardians, usually it's a woman, it's a grandmother or a sister of one of the parents who died. Women do most of the caregiving, as we know, so women are taking on these kids. And they were just saying one of the hardest things is, how do I help this child with the sadness? I'm not sure what we need to do to help this child with the sadness. So starting in 2009, I collaborated with this group to try to see if we could take some of the treatments that we developed here that had strong evidence and principles that we thought would fit cross-culturally, but we needed to find out if they did. And we needed to find out if lay community people could deliver them. So starting in 2009, we started focus groups with youth, with caregivers of orphans, trying to figure out if a treatment, it's a cognitive behavioral therapy. So meaning it focuses on your thinking and your behavior. And it does that exposure lens that I talked about. So you talk about what your traumatic event was, which for these kids was death of one or both parents, and often the circumstances of the death. Many parents didn't realize how much kids were picking up on. How many of you are parents, if you're comfortable saying? Kids pick up on so much more than we think, would you not say? Like, you think they don't know something, and then you realize. We had a kid describe everything about a medical emergency of a parent who died that nobody would have thought a 7-year-old was grasping. But they remembered where the boil was on the father's leg, and they remembered the infection, and they remembered the mother running for a neighbor, like the details that this kid remembered. But because people don't think kids remember, we don't always ask them. And so this kid was just holding inside the memory of the night his father died. And the mother, once we realized all that the kid knew, the mother and child talked about it, and she comforted him, and they were able to resolve things like, well, I didn't know why you were screaming. Oh, I was just screaming because I wanted to get help. If we could save your dad, I wanted to get your dad. I wasn't worried about, the children are upset or anything. So there's so much that can be processed, but we wanted to see, could lay counselors learn the treatment, because no one had done an exposure trauma-focused treatment for death before, when the treatment had been developed in a completely different cultural setting. We needed to adapt it so that it would have idioms and stories that would fit the Tanzanian context and the tribal context of the region where we were, which was Moshi. And then we needed to see if it would be acceptable to children and guardians, and where we could deliver something like this. We ended up doing it in the schools because they're community spaces. We did it on the weekend. And the lay counselors, to fast forward, the lay counselors we trained in 2009. In the next study were the trainers for lay counselors in Kenya and Tanzania. The Tanzanian counselors who were the trainers, they came here to Seattle. We planned the training. Learning a treatment is one thing. Learning how to train other people is kind of a different set of skills. So you take a brilliant counselor, you just layer on, and again, you practice. How do you learn to be a good trainer? You practice training. What gets your crowd engaged? How do you know if someone's struggling or doing well? How do you build up the people who are doing well so they can support their peers? And so we spent a lot of time building all those skills in these brilliant counselors. They were much better trainers than I was, because I'm a Mzungu and a white woman from the US, and I'm not Kenyan or Tanzanian. The Tanzanian counselors, even though they weren't Kenyan, there's a lot of cultural overlap because it's colonization that split the countries where they are, right? So there's a lot of overlap culturally where they could bring things to the training that I could never bring. And I just supported them on the content of like, okay, I think folks are getting sleepy. We probably need an icebreaker or an activity. And those Tanzanian counselors trained the Kenyan counselors and a team of Tanzanian counselors. They worked together across both countries. Fast forward to now, and Clara's been involved in a lot of this work. The 6 Kenyan counselors trained 140 teachers in government-funded schools, 140 community health volunteers who delivered the treatment with effects that were just as good as the 6 in Kenya and Tanzania who were trained by people that I directly trained. So you get to see this scale, especially when you empower people to understand all I brought you is the treatment knowledge. Now you have that and you have everything else. You know the schools, you know the communities, you know the culture, you know the language. And so we've really just been able to see these lay counselor models if you support people and you have the ability to do it. In the US, licensure stops us from using lay counselors to do a lot of things. There's a BA credential in Washington and we're using it more and more, but it makes it hard to do here what we've done very successfully in Kenya and Tanzania and many other countries. We have a different treatment model in Mozambique, but using the same model. We call it an apprenticeship model because as you learn to be a counselor, then you can be a supervisor and you apprentice the next level of counselors. Then if you're a supervisor, you can then become a trainer and you can apprentice the next layer of supervisors and counselors so that you're just continuously building up expertise in a community to keep delivering care. All right, that was a very long answer, but I'm very passionate about this piece of things.
Well, and I'll throw in a couple of, before I, do whatever whammy I'm supposed to do next. I will throw in a note of optimism, which is that there actually has been a lot of progress made, and some of it very, very recently in many states to provide reimbursement for services that are provided by peer counselors. And of course, the idea of having peer counseling and peer support goes way back. And just recently here in the state of Washington, the Healthcare Authority, which is the agency that pays for Medicaid, released its fee schedule that will allow the services of community health workers who are based in primary care to be reimbursed by Medicaid. And those community health workers are wonderful and very crafty characters. I don't know if any of you have ever actually worked as a community health worker or worked with one, but the boundaries around what community health workers can do are beautifully vague. And while they are, of course, mostly supposed to be, doing care navigation or helping people to link up between services, they're clearly doing a huge amount of emotional support, and there's lots of work already, going on in terms of what kinds of training they could get to do to administer, either cross-cutting or even in some cases fairly specific, forms of mental health care. So I think we're getting there here. We'll see what happens. There is sort of an interesting common theme in some of the stuff that we've talked about, and so I can get to ask my question of everybody is, what do you think, and you may know the answer to this, is the most common way that mental health problems are brought to people's attention when they come, to their doctor? What would you say is the most common way that they get presented, to use our doctor word?
Maybe through some physical manifestation like inability to sleep or something like that?
Exactly, that's it. By far and away, somatic, a fancy word, presentations, headaches, stomach aches, can't sleep, change in my appetite. Why do you think that is? There are a bunch of possible reasons, or a bunch of reasons that.
They possibly can't relate that with anything else happening.
I'm sorry?
So maybe the kid is presenting with headache or they can't sleep, but the parent or the guardian cannot associate that with anything else. So maybe
Yes.
they suspect they could have mental health.
Mm-hmm. Yeah, so that's certainly one reason is parents bring it in because that's what they're saying is the problem. What other?
No,
also could be a lot of stigma related to mental health
Yes.
issues. So most times people need to find a physical way to describe what is happening.
Yes, yeah, I mean, so sometimes it's stigma, a lot of times it's stigma. This is a legitimate way to come to the doctor as opposed to coming in and saying I'm depressed or I'm anxious. And then the other thing is that in fact our minds and our bodies are connected. Sometimes, I don't consciously think that I'm stressed. I'm just having a lot of headaches, and somebody has to help me kind of make that connection. So there are lots of reasons why people come for medical care and don't tell their clinician about it. And we used to have a kind of a rule here in North America. We used to call it sort of the 50-50-50 rule, which was that like half of parents who are bringing their child in for medical care, if they have a concern about emotional or behavioral problems, won't tell the doctor that. Half the time when they do tell, the doctor will ignore it. And half the time, if the doctor pays attention to it and makes a referral, the family won't go.
That's very depressing.
Well, and in fact, the situation is it's not great here. It's potentially even worse in other places. When we started doing our HIV work in Ethiopia. I mean, what would you guess was sort of about the average length of a visit for someone coming back for their sort of return HIV care? It was more like somewhere between 3 and 5. So very, very, and it's nobody. The systems are incredibly sort of overwhelmed. What would you say the clinical circumstances would be like? Do you go in your private examining room and have someone close the door?
Like much privacy as such. So in the open space and the need to kind of clear the queue, so we, kind of these questions, how you getting on with the medication and if it's well,
Right, exactly. You might be in a room with 4 or 5 desks and visits going on simultaneously. The window may be open and the people sitting on the bench outside may be able to hear what you're talking about. And so the setting is not necessarily conducive to disclosing some sensitive information, let alone the fact that you're here talking about an illness which is itself stigmatized. So one of the things that many people have done has been to try to think about both the structure, the content of primary care visits to make them more conducive to people being able to talk about emotional problems and the things that are bothering them, and particularly traumatic things. I think the other thing that we think about a lot when we think about sort of mental health approaches to trauma is this idea of chronicity, and the idea that it is wonderful that there is a treatment. And what I'd love to ask Shannon about is her experience. For example, you told some wonderful stories about kids who were able to finally talk about experiences that they had had. One of the things that, if you're into sort of child development, is that children wonderfully change as they grow up, and as they go through different developmental stages, different kinds of memories, different sorts of challenges kind of resurface, or they take on new forms, or they take on new meanings for people as they get to different stages in their lives, how do we, this is one of the huge, back and forths in sort of all of mental health services, all over the world, is how do we offer what is essentially episodic care for what's really a lifelong condition or issue? And so I'd love to hear Shannon's thoughts on that.
Yeah, I'm not sure anyone's solved this one, but we do two things, I'd say. I feel like more and more our treatments build in this idea of relapse prevention. So how will you know if this problem is occurring again? So if you start thinking more about the traumatic event, or if you're treating depression. And what's interesting about treatment of depression, we have great treatments for depression, but if you're traumatized and your depression partly stems from trauma, our great treatments for depression don't work. You need something that is informed by trauma care. So it's interesting that we've sort of learned, that trauma just underlies so many things, and it's so critical to screen for trauma when you provide any kind of mental health care. It's part of the picture for a lot of kids of what's going on for them mental health wise. But I think a lot of our treatments have built in this idea of relapse prevention. It doesn't totally solve this episodic care thing, but it helps train the person who's in therapy to be their own therapist, to learn, how do I know if this is happening again? How do I think about when I need help versus when I think of mental health therapy a lot as physical therapy. So you know how physical therapy only works when you're doing the exercises? It's not just that someone tells you how to rehab your knee, but every day and every week you have to do those exercises. Taking care of yourself if you're experiencing depression or you re-experience depression, you have to restart all those exercises. So I feel like relapse prevention trains people a little and lets them know we think it's normal, that this will reoccur. We're not trying to scare you that you'll be depressed again, but depression comes and goes. Thinking about a traumatic event can come and go. What are the things that work that you might need to put into play? And when would you need to seek a professional to help you again if you need it? So I think that's one thing. But one particular element of the intervention that we do, it's called trauma-focused CBT in the US, and we call it Pamoja Tunawesa in Swahili-speaking areas. One of the things we do there is something called the circle of life, and it's helping kids see that the year is a circle with repeated events, and there'll be your own birthday when you might miss your mother more. There'll be your mother's birthday when you're going to miss her more. There will be holidays, and it helps kids prepare, and their guardians that care for them, because otherwise sometimes guardians are like, why is this kid misbehaving right now? Like, why am I seeing all these problems? And it might be the anniversary of the death. It might be the anniversary of the birthday. And without educating families to prepare for those, it's hard. And then the other thing we do with the circle of life in this treatment is help people think years ahead. So at your marriage, at your graduation, at a particular religious event, you're going to feel that loss in a different way. And so how can families prepare that when it's death, this impacts you now, but you're going to be hit in different times. Like that's what we always talk about here, the holidays are so hard for people because if you've experienced a lot of loss, then times when families come together, you really notice your family member who's missing. So this treatment does a little bit to try to prepare people for that, but it doesn't answer the full question.
Well, I think that the thing that this brings out so nicely is that ideally what we're working toward is this system where there can be a flow of people back and forth between more specialized mental health services, regardless of whether they're being, offered by people with lots of letters after their name, or whether they're people who are community-based, providers who've been trained in this way, and the primary care system, because the ideal of the primary care system is that it's always there, and that there is this continuity. You can always come back. So the thought is, if you can always come back to primary care, and the primary care folks can recognize either how to boost what you've already learned. So a very important thing is that even if I'm not doing the kind of treatment that you're described, I should know enough about it to be able to say, do you remember what you might have learned from Dr. Dorsey and her group of therapists, do you want to try to think about that a little bit more? But do we get to a point where you might have to go back, for another dose, and that might happen at any sort of a particular time. Go ahead.
Well, one of the things I wanted to have you talk about today, because I think what you just said is so critical, that the school system or the primary care is where kids and families are always connected. But when we think about our own medical visits, or you think about taking your child to the pediatrician, I wondered, so some of Larry's work has shown, and I wonder if you could talk about this work and then also a potential solution, but some of Larry's work has shown that the way a pediatrician talks to a family, specific skills will change how open they are to telling you about an issue or a concern. And I just wonder if you could speak a little about that work, but also about this time barrier. Like, so many times we want to add everything to a pediatrician's plate because they see families at every critical juncture, but everybody wants to add everything to the pediatrician's plate. So I was curious if you'd speak to how do we maximize that time? Are there other people you imagine in the integrated care system, like in a clinic, or that could support this work? How do we accomplish it with the way the medical system does keep crunching people's time for primary care?
Well, are there any of you here who are in health communication? No, okay. Part of the dilemma, going back to the way we're, have these blinders on from the health systems that we happen to have sort of grown up in, is that in the United States, we actually have a very weak public health system and an even weaker system of public health education. We don't do much of it in schools, we don't do much of it in the community, and so a lot of it devolves into primary care, where the joke for us when we were going out to pediatric practices and trying to do some teaching around some of this mental health stuff was that we were just standing in line behind the person who was coming to try to convince the pediatricians to do a better job with car seats, or to do a better job with fluoride varnish, or a better job with immunizations, where all of that is meant to be sort of done within a medical visit. Whereas, let's say in the UK, very little of that stuff happens in the GP's office. It's all taken care of by public health people, or it happens in schools or other places. And so certainly one answer is we know that no one person or one venue can really do this stuff, so it's got to be spread out. I think the other thing, though, is that in this country, as in so many, we're still really fighting this idea that when you come to care, the high and mighty clinician is supposed to tell you what to do, and you're not really supposed to ask them much of anything or talk to them very much. And our work has really been around trying to help clinicians feel a little less anxious about opening up the space for people to just say, this is what's bothering me today. And at least one of our arguments is that that's actually very efficient, because if you take care of what is really bothering people, there's a chance they won't have to come back. Because going back to the headache, what you're talking about, if the headache really is something that's not going to be made better by a few acetaminophen tablets, then the family is just going to keep coming back because the headaches aren't going to go away. And if it turns out that they're really from trauma or loss or grief or stress in some other way, the system is just going to keep churning that person until you understand what it is. And then, of course, there's the clinician's worst nightmare, which is, yes, we've wrapped up the visit, and as the family walks out the door, we have a joke for this. I don't know if any of you have heard this expression, the doorknob question, which is that as the family's hand is on the doorknob and they're walking out of the exam room, they say, oh, and by the way, she did say the other day that she was thinking about killing herself. And I'm making a joke about that, but that's a heart sink moment. You have to pay attention to that, and you have to and it can be a heart sink moment over things which are fortunately much less serious than that, but still urgent that the family really, needs to be taken care of. So we try to make the point that that finding out what people really want to talk about and what really has brought them in is actually, going to be more helpful than trying to ignore it and just cram everything into this visit. Are we at a point where we should ask if people have questions or things they want to?
It's 12:30, so up to you.
Okay.
Well, I might share one more thing that you just
Okay,
brought up that made me think about it, just because I feel that these are chances to just put a few things out there. What Larry was just talking about, there's this interesting tension, and we were talking about this in our lab yesterday, between how effective an intervention is and how many people it can reach. Sometimes the more effective the intervention is, the more sessions, the more you have to train the provider, the more time you need with the child and the guardian. But those often don't reach as many people because they're not as easy to scale. And I'm looking at myself because I'm a clinical psychologist, and a lot of our interventions, we're 12 sessions, and I've pushed things down to 8. And in another project, I've pushed things down to 5. And that's still not quite enough, because when you're not, even teaching someone to give a vaccine well is challenging. But if you're training someone to deliver a treatment where they have to deliver, and we've had conversations, Leah and I have had conversations with many of our colleagues about mental health interventions, you're teaching someone how to deliver maybe 5 to 6 skills that are different with each person you talk to, because all people are a little different. Now, maybe all arms are different for vaccines too. I don't give vaccines. But, somebody comes in with a problem with a sibling, and someone comes in with school challenges plus the depression. So training someone to be able to treat lots of different kids or lots of different individuals with 4 or 5 skills takes more time than you would think. And it's not just training, it's supervision. We have to teach you how to do it, but then the first person you see, you're like, wait a minute, this is different than the training. So there has to be, a colleague of mine calls it training part 2, is the supervision. So when we roll out mental health interventions, people are often surprised how much ongoing support is needed. But if you want to see the good benefits, they have to not just be trained, but supported in delivering it to different individuals till you get a feel for it. But that just can bring up this tension between effect and reach. And I wanted to just mention a colleague at UW a while back did a study with a bedside intervention that didn't have a great effect. It helped people, but just a little bit. But you could deliver it at the bedside in it was a trauma hospital setting. It was in the Harborview Trauma Center. So you could deliver it at the bedside after someone had had this serious medical emergency. The other intervention, you had to walk from here to there. So after you got out, you had to cross the street to another building and get care there. And that effect was a 0.5, which is a pretty good, a modest effect. It worked pretty well. But almost nobody followed up on the referral. That's what I'm saying, the 50-50-50 thing. So if you scale that up to the population level, what is the population benefit? This is the population health initiative here, right? So what is the population benefit? That little bedside intervention that had the tiniest effect had 12 times the population benefit than this one that was fabulous, and you walk across the street. And in my discipline as a clinical psychologist, I think we too often focus on the effect of this intervention. And it's why sometimes people won't give their interventions to communities, to let lay people deliver them and adapt them to be right for your kids, your community, your setting. But it's also why I encourage all of you and us, we have to design things that are easier, simpler, even if they have smaller effects, if they can be scaled up, because otherwise we're never going to tackle this mental health problem that is so prevalent. So I just wanted to mention that reach and effectiveness tension, because it's pretty important. Okay, that's now I'm done.
Well, and the one thing that I will say about that is that I also think, although this is maybe a little bit of a technical thing, and are there any statisticians? I can get away with saying this. I think that also I think that the effectiveness of some of the things that we think are highly effective is actually greatly exaggerated, because that effectiveness is usually determined in a study where we have studiously taken out anybody who has any sort of a chance of not responding to the problem. And I think your allusion at the beginning, talking about how trauma is much more prevalent than we think it is, and how it changes the treatability of these actually not really pure categories anyway, because we're throwing out the DSM too. So I think that one of the biggest problems that we have with those very highly evidence-based treatments often is that once they get out into the community, we're giving them to people who are really different than the people who they were tested on. So I know this is a big discussion, and I
No.
probably got half of it wrong.
No, I think it's good you said that. And our work, everything that we do is in the settings where the care would get delivered. We don't do anything in lab-based settings. We don't do anything with people who wouldn't get the care just showing up at their regular school or their community, because that matters. And if you don't test your treatments where they will be deployed, the evidence is basically useless to some degree. So that is critical.
Which I think is a great sort of parting shot for a lot of this whole sort of global mental health work, which is really transferring promoting the expertise for doing it, whether you call it capacity building or whatever. The work really has to get done where the people are who are going to use it. So anyway, the easy thing to say.
So do folks have any questions? If you need to get a cookie or some snacks, grab those as well. But
Here, I'm going to play.
oh, here you want this one?
Nobody knows what who
Take
Geraldo
this one, Larry. Take this
Okay,
one. This
right,
is easier to pass
right,
around than that
Nobody knows who
lavalier one.
Geraldo Rivera is.
I do.
You do, okay. Those of us of a certain age. Here it is.
Okay, thank you. Yeah, okay, I'm Judy. I'm actually a counselor and from Kenya. So I really, I support what you are saying, that training lay counselors is very important. And also the context in which a lot of mental health problems come up, also is with the religious institutions, the mosques, the churches, and we're finding increasingly mental health issues are being talked about there, like having sessions on that. I don't know how you see then the profession of, say, counseling or clinical psychology, because I like in my country, I've seen a lot of doctors or other professionals getting some training in counseling, but at the same time, we're saying that training the lay workers to deliver, which is very effective, is actually ongoing. So I don't know how you see the future of this clinical training, but also whether there are these forums where the lay counselors can actually present at conferences or such places about their work. Are there any?
That's such a good question. A lot of my colleagues at the University of Nairobi do what you're saying, both train, people who are in the professional programs, but then also are involved in these lay counselor training efforts. And I don't know as much about the conferences. We have sent some of our lay counselors to a few of the mental health, because after the mental health policy came out and with mental health day and things like that, I feel like they have done some presentations. The interesting thing, I think some of the lay counselors have felt less comfortable with the big formal presentations than someone who's coming through, a university or a graduate program might, because that's a totally different skill set, developing a PowerPoint and talking to other professionals versus training people. But I feel like you probably have better answers for that than me. But I did want to say, when you said the churches, I did want to mention, we saw some neat things where if our teachers were doing mental health intervention in the schools and they were trained to deliver this, then their pastor or someone at their church would ask them to deliver some lessons and be an expert in the church as well. And it was neat to see that transfer because of everything that you said. Oh, I was just going to add on, I'll say one of your points. I feel like we need to keep training people in clinical psychology and counseling and the lay counselors, just because of the fact that at one point when we were doing the work in Bungoma, the closest psychiatrist was in Kisumu. So, he was 2 hours away and then he retired. And so when they had an emergency that they needed a mental health professional, there was nobody close by. And I would love to see a tiered system, even that apprenticeship thing where, because we need this here too, because our mental health professionals don't meet the need. But if we had the ability to have people who are in the counseling and in clinical psychology and lay counselors work together in kind of a tiered system to reach everybody, I would love that.
Well, in fact, there was a program that started in Harare in Zimbabwe, which has, reached, it's almost a mythical program now. It's spread all over. It's called the Friendship Bench. And many of you may have heard of it. That had lay counselors who were doing counseling for depression and linked them to psychologists in the community in a very novel sort of a way. They had a tricked out smartphone, and if in the course of a session or afterwards the lay counselors felt like they were out of their breath or they were worried that the patient wasn't getting better, they could signal on an app that they needed a consultation, and if there was a group of psychologists in Harare in the community who could respond if they happened to be free at that moment to talk about it. So I think there's a need at every level, and there are certainly the cell phones and things like that have now made it possible for collaborations like that to happen in ways that we could never have thought of before, even over large distances. So in that sense, I totally agree with you. Is there a question over here?
Hi, I'm Mariam. It was a really good session. I kind of skipped class to be here, and I'm really glad I did.
Who needs to write you a note?
No, it's okay. So I basically have two questions. One of them is that we often talk about like the stigmatization of mental health and like working towards destigmatization. But at the same time, I feel like there's also this trivialization of mental health where we're like, a lot of people in like the younger generations would be like, I'm depressed, I'm traumatized, I have OCD, to describe like sadness, a bad event that's happened. And I personally feel like it kind of pushes the people away who actually face like depression and anxiety from treatment, because it's like this happens to everyone and this isn't a big deal. So how do we kind of deal with that, and is that in your opinion like a big issue? And the other thing was like you mentioned that the interventions here in the US are kind of like contextualized to whatever area you're applying to, but especially like lower middle income countries with a vastly different culture than the US. Like the US has a more individualistic approach to life. So often like these concepts that we hear about in like therapy and mental health spaces, like boundaries and stuff like that, they don't apply to other regions. Like if you tell someone from like, I'm from Asia, so if you tell me to tell my mom that I need boundaries and I'm not gonna talk to you once a week, my mom is gonna like flip out, even though she's like very aware of mental health. So people who aren't aware of it, like how do you like kind of move away from you using these westernized approaches to more like localized approaches? Thank you.
I love that, and I'm gonna answer the second one first, because I'm very passionate about the second one, and I don't know that I have a great answer for the first one. So for the second one, I feel like you can't do any work anywhere without expertise. And all that I bring is expertise in an intervention, unless it happens to be, you can probably tell I'm not from Seattle either. I'm from Georgia, which the South has its particular own cultural context. I would never work anywhere without partnership of folks who are experts, lived experience in the community. And the neat thing about a lot of these interventions is there's a core thing, like how you think affects how you feel and behave. But other than that, the rest of it can be adapted. How do you talk about it? What's the appropriate way? But so we try to take this core piece, like how you think can change how you feel. So for example, if your parent died, we can't change that situation, but we can change some of how you think about it. And how you think about it might be dependent based on the context and the culture that you live in. And we aren't, telling kids how to think about it. We're finding out how they think about it and then what are more helpful ways to think about it. So, a lot of things that come up for kids are like, no one will love me like my mom did. I'm alone. No one else has been through this. But I don't have to deal with it as a Westerner from the US who's not Kenyan. My Kenyan colleague who's learned the intervention in that core piece can then take it and work with the kid in the room. So one thing I really love about the way that we work is we take these core pieces. Also, like if you don't talk about what you lived through, it is hard to get over it. But how you do that, how quickly you do that, I mean, pole and dio moendo, like slowly is the way, there are idioms you can use different places that work regardless of where you are, as long as you have a cultural expert. And I think that's a mistake that people make. My students write about this in their essays and in their case presentations. You can't superimpose a Western culture, especially on child and parent relationships, because parenting is one of the most culturally bound things that there is. It's how we express our culture, how we raise our children, how we raise our families. So the nice thing is ensuring, with the way that we work, ensuring that the communities are always in charge of how it's adapted. And when I know I've been successful, somebody is editing our manual, they're changing the pages, and my goal is to empower people to feel free to do that. Because it is hard to break down the power you bring in if you're a psychologist and a professor and you're bringing in this treatment and you're saying, I want you to make it, to tailor it like you would a dress, right? You buy a ready-made dress, but you have to tailor it to fit. That's kind of what we're doing with the interventions. And I think that makes a difference, because otherwise I don't think you can transport. My work, because my expertise is evidence-based treatments, my work has been helping people tailor those, but there are lots of colleagues in global mental health, Deepa Rao and other colleagues of mine who've tried to look at what's already happening and scale that up. And I think they're actually both very important approaches, because in some areas we don't have something for like trauma, but we may have other things that work. So I think you kind of need both. But the West has a history of transporting. What I also love about our work, I'll just say, is a lot of my US-based colleagues have been trained by some of my Tanzanian and Kenyan colleagues, especially around expertise around dealing with death. They've given presentations here for the state and a state project that I have, so that we're sharing information both ways. The first one, I don't know what to say about that. Do you want to say anything about the trivialization? Because it's a good point. Like, I'm careful not to say I'm traumatized by things that I haven't actually felt I might die or someone close to me might die, but I don't know. Do you have anything to say about that, Larry?
Well, I think things get into the culture. I'm old enough that, if you came from anywhere around, New York City and anywhere from the 1950s sort of on, you spoke of everything in terms of sort of Freudian psychology. I'm anal. But a lot of us still use that expression. I mean, people forget where it came from. That's Freud's. It's your anal stage. But the bottom line is, I think that at least as clinicians, part of what we're trying to do is to understand when that's just a figure of speech, when it's sort of a test, like, oh, I'm using this word and I wonder how you're going to react to it, because there's actually a whole lot more behind it. And so sort of take the idea that we can't afford to ignore those things. I think on a larger sort of public health level is to sort of think about, well, why are people using that terminology for describing their experience as opposed to something else? What does that tell us about the resources that are available in communities, the acceptable means of expression for distress? One positive way of looking at that stuff is actually exactly as you said, that okay, now it's destigmatized and that's a good thing, but it still means now we have to figure out how to filter out who are the people who are really using that expression as a bid for help, as opposed to people who are using it as a way of just simply expressing, how they feel right now, and looking for other people who might like to say back to them, yeah, I feel the same way too. So.
Thank you for this wonderful conversation. When you were speaking about task shifting, I was thinking of task shifting to like chatbots, which are becoming as the I guess tech industry would promise that it would lower the barrier to mental health service access and also make it more widely available, accessible, affordable. But from your perspectives, based in the US, also in other countries, how have you been engaging with that emerging technology? What have you been communicating with your counselors, the people who are going to be trained about working with or not working with pets?
That's a great question. I mean, I think it can be answered at a number of levels, and I can only answer it at one. I've been involved with a school-based mental health program that has developed a chatbot for teachers, and to the extent that it is it's a decision-making tool for the teacher.
In Pakistan, right?
Yeah,
in Pakistan.
Pakistan, to be able to think about, I'm gonna sort of enter some, it's a very primitive chatbot compared to things even now, because it was from a few years ago. Put some symptoms in and have the chatbot kind of tell you, well, have you thought about this? Or here's some information for you. I think those things can be, terribly useful. I don't know, any of you here are Linux computer people by any chance? I mean, one of the early versions of Linux had a program in it called Doctor, and it was a Freudian psychiatrist program that gave you random questions that said, do you think that has anything to do with your mother? Or, could it be that this relates to an earlier conflict? I mean, it would randomly put those sentences out, no matter what you put into it. But it was food for thought, and you could say this is so. Could these things potentially be very useful? Yes. There has been some nice work done looking at, and again, this goes back a couple of years, and the field changes so much. Looking at online self-help tools, which showed that those tools seem very helpful, but they also seem even more helpful when they are done with a coach. So I think, to me, the really exciting thing about this is sort of guided use of those kinds of tools. So here's the chatbot, here's an online, kind of a self-help program, and let's talk about why we think this is a good thing for you. Let's think about what you might get out of it, and come back and talk to me about what you're learning. So I think they're wonderful extenders, and people are doing a lot of fun work doing with that. Whether will they ultimately replace, talking therapy? I have no idea. It's a wonderful thing to think about.
It's 12:54. I know, Larry, you have a 1 o'clock meeting. I wanted to just say that our previous presentation had a team of researchers that talked about the development of a chatbot. Do you know about that? Yeah, so there's a recording of that presentation. It was really fantastic, and I encourage you to watch it on our website. It's on the DGH webpage. Do you guys have any last things you want to say, or is there one last quick question? I think we kind of need to wrap up. Okay, I didn't say this at the beginning, but I want to thank our Population Health Initiative folks. We are partners in this effort, and they are responsible for all the soothing music and the good food, and so yes.
It is awesome.
Yeah, thank you so much.
And just grateful to have their partnership. So thank you so much. Let's give a round of applause to Larry and Shannon.
Giving us the chance to reflect in this moment of peace and to look out into your enthusiastic faces and know that there's hope for the future. Thanks.
Thanks for skipping class.
Yeah.
yeah, it was really fantastic. I learned so much.
Thank you all. Have a good rest of your week.
Yeah.